Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today I'm going to be talking about Hodgkin's versus non-Hodgkin's lymphoma. This is per request. Somebody asked me to do this, and I have never covered this before, so let's go ahead and do that. Hello, Clinic Review family. Thank you for being a part of our family. You know, this channel is part of the greater Clinic Review organization. If you go to clinicreviews.com, you can find our very excellent NCLEX review. It's 21 plus hours of NCLEX prep taught by the GOAT himself, Mark Klimek. Yes, he is still alive. And he also has, you get the yellow book. I'm sorry, you get the yellow book to go along with that. There's also questions. He goes through questions with you and so forth. You can actually go, if you go to clinicreviews.com and you click on demand, the option for on demand, there's actually a free video you can watch about aminoglycosides that kind of shows you what it's all about. So you can go there and do that. We also have a streaming service, and we have small group tutoring that I teach 2 of the sessions, and Pete Savard teaches 2 of the sessions. That's where I talk about next gen stuff. That's why I don't cover next gen on this channel, because it's a service that we provide for a fee. All right. So let's talk about Hodgkin's, non-Hodgkin's versus Hodgkin's lymphoma. I need to bring up my notes just real quick here. So this is a lymphoma. It is a blood disorder, and it is a suppression of the immune system. It primarily involves the lymph nodes. That's why it's called a lymphoma. And the earliest symptoms of both types of lymphoma, both Hodgkin's and non-Hodgkin's, is enlarged lymph nodes. Couple differences between Hodgkin's and non-Hodgkin's. First of all, Hodgkin's is more easily treated if it's caught early. Okay, Hodgkin's is more easily treated. And it is more likely to occur in young adults, so under the age of 35. Hodgkin's, the less serious type, more likely to occur in young adults, and those over the age of 60. Non-Hodgkin's is more difficult to treat, and that tends to occur in older adults over the age of 60, 65. So the Hodgkin's is the more easily treated. They both have enlarged lymph nodes. The Hodgkin's will occur in children and older adults. Non-Hodgkin's occurs just in older adults. And the main difference when you look at these things under a microscope, because they both involve cells in the immune system. So B cells, T cells, killer cells, natural killer cells. That's what they're called. Natural killer cells. You don't have to memorize that. I'm just telling you. The difference is in Hodgkin's lymphoma, the B cells are enlarged. Okay, the B cells are enlarged. They actually have a name. They're called Reed-Sternberg cells. Reed-Sternberg cells. That is a characteristic of Hodgkin's. So when someone comes in with enlarged lymph nodes and they think they might have some type of Hodgkin's lymphoma, they do a biopsy and they look for those Reed-Sternberg cells. And if those enlarged B cells are present, they say, well, it's Hodgkin's. Now, Hodgkin's is easier to treat because it tends to remain concentrated. So if the lymph nodes are enlarged in the neck, that's probably the only place they're enlarged. If they're enlarged under the arm, that's probably the only place they're enlarged. If they're enlarged in the groin, that's probably the only place they're enlarged. Non-Hodgkin's tends to occur more randomly, so it's more widespread, and you can't really predict where it's going to be. So if you feel them in the neck, you may also feel them in the groin. You may also feel them under the arm. Okay. Both of them have painless enlarged lymph nodes. The lymph nodes enlargement is not painful. And as the disease progresses, they can start to have what they call B cell symptoms. B cell symptoms are sort of what you think of as how you feel when you're getting a fever. Okay, so night sweats, when you wake up in the middle of the night and you're sweating like your fever just broke. So these B cell symptoms include night sweats, fever, and weight loss. So that usually, if you don't catch it until they have night sweats, fever, and weight loss, it's not early. Usually you want to catch it early by palpating the enlarged lymph nodes. Okay. That's sort of the earliest sign. So they both are treated with chemotherapy. They have different chemotherapies because they do have a slightly different pathology. So they're both treated with chemotherapy, and they can both be treated with what we call biologic agents. So the term chemotherapy just means chemical therapy. Any medication that I give you is considered a chemical that I'm putting in your body. Well, any pharmacological therapy that like is a chemical, right? So steroids are chemicals, antibiotics are chemicals. And both of those things can be used to kill cancer cells. Antibiotics stop the reproduction of various viruses and bacteria, can stop the reproduction of other types of cells. Steroids is an immune suppressant, so that can actually kill cells. So both of those things can be used. That's chemical therapy, right? Then there's another type of therapy that I don't know when it started to come out. It probably started coming out maybe 25 or 30 years ago, but it's widely used now. They're called biologic therapies. And these biologic therapies are things that they created that mimic biological proteins in the body, but they're not like chemicals that we put in the body. There's the chemicals we put in antibiotics and so forth. We don't have any of those same chemicals in our body. If you do a biologic agent, it's something that's created in the lab, but it mimics something that's in our body. And so we can give biologic agents, and then often we treat this with some types of biologic agents because it is a B cell, T cell, natural killer cell disease. We can actually rev up their immune system because their immune system is a bit suppressed with this lymphoma. And so we can rev up the immune system so that they can start to kill some of the lymphocytes that are not good. Okay. So we can treat it with chemotherapy. We can treat it with biologic agents. We can also treat it with radiation. They can, if they know right where the lymph nodes are that are affected, they can treat it with radiation. That's another way they can treat it. Okay. So that's sort of an overview. If you end up working with patients who have non-Hodgkin's or Hodgkin's lymphoma, I'm sure there's a lot more to know. That's just a very general overview. So let's do some questions and see if I can help you understand this a little bit better, okay? A nurse is assessing a patient suspected of having Hodgkin's lymphoma. Which findings would support this diagnosis? Select all that apply. So Hodgkin's is the less serious one, more easily treated, tends to have isolated lymph nodes. They don't tend to travel all over the body. All right, so painless enlargement of a single group of lymph nodes. Yes, that's Hodgkin's. Presence of Reed-Sternberg cells in the biopsy. Yes, that's Hodgkin's. That's how we differentiate it from non-Hodgkin's. Multiple extranodal sites of involvement. No, that's non-Hodgkin's. High fever, night sweats, and weight loss. That is true. That's true for both of them as they progress. So now if they have those symptoms, they're pretty far along, but they still are symptoms of the disease. So yes, commonly diagnosed in patients over 60. It's actually diagnosed in younger and older patients. So Hodgkin's is both. And so I'm not going to pick that. Link to the Epstein-Barr virus infection. That's actually true. Hodgkin's lymphoma is actually associated with the Epstein-Barr virus infection. You can just memorize that. I don't know if that's something you would just be able to figure out on your own. So those are the correct answers. So that is kind of what characterizes Hodgkin's lymphoma. A nurse is providing teaching to a patient undergoing radiation therapy for Hodgkin's lymphoma because they have isolated areas of nodal enlargement. They can do radiation. Which statement indicates effective learning? I can use lotion on the radiation site if it becomes red. I should protect the area from direct sunlight. I can scrub the radiation site gently with soap and water. I should use heating pads to relieve skin discomfort. So the key thing that as it relates to radiation is that you have to be very, very careful with the skin because radiation always goes through skin. No matter where you do the radiation, it always goes through skin somewhere. And it can cause a lot of problems with the skin. It's very irritating to the skin. And you have to be very careful what you put on it. You can't put anything that is alcohol-based, like no lotions that are alcohol-based, and most lotions are alcohol-based. You have to use very, very mild soaps. And sometimes you don't even use soap. Sometimes you just use water and never scrub it. Okay, that's never good. And don't put anything hot or cold on it. Like you have to be just very careful because it could just slough off if you put something too hot or too cold on it, and it could be quite painful. So I don't love A. I mean, there are certain types of lotions I can put on it. So it's not a great answer, but it may be right. Okay. Now B, I really like because I do need to protect it from direct sunlight. It's already going to feel like a really bad sunburn. And if you let it get into direct sunlight, it's going to get even worse. So I really like B. I don't like C and I don't like D. So I'm crossing those off. So remember, I've told you that it's better to pick the answer you know is right than the answer you're not sure. A, I'm not sure, but I really like B. Like, I'm sure B is correct. So I'm going to pick the answer I'm sure about rather than the one I'm not sure about. And you could say, well, but maybe it's a lotion that doesn't have alcohol base. Well, it could be, but I know for sure B is correct. I know I have to protect it from the sunlight. A patient diagnosed with non-Hodgkin's lymphoma asks how it differs from Hodgkin's lymphoma. Which characteristics should the nurse include in the response? All right. So non-Hodgkin's is the bad one that occurs primarily in older adults, has scattered lymph node involvement. It's more difficult to treat. And Hodgkin's lymphoma is the less severe one. It has isolated lymph nodes, and it occurs in both children and adults. Even I have to think about it for a minute. That's why I'm going through these questions with you. Non-Hodgkin's lymphoma often involves multiple lymph nodes and extranodal sites. That's true. So that's why it makes it harder to treat. Hodgkin's lymphoma has a more predictable spread from one node to another. That's true. Non-Hodgkin's lymphoma is more common in children. False. It's more common in older adults. Hodgkin's lymphoma has a higher survival rate compared to non-Hodgkin's. That's true. Reed-Sternberg cells are seen in non-Hodgkin's. False. Reed-Sternberg is in the Hodgkin's because Reed-Sternberg are those enlarged B cells, and that's how you diagnose Hodgkin's. Non-Hodgkin's can be either slow growing or aggressive. That's actually true. There are types of non-Hodgkin's that are much less aggressive. So just because someone's diagnosed with non-Hodgkin's doesn't mean that it's a death sentence. There are some that are much more aggressive and some that are less aggressive. So that's actually a true statement. A nurse is assessing a patient undergoing chemotherapy for Hodgkin's lymphoma. Which complications should the nurse monitor for? Select all that apply. All right. So it doesn't say biologic agents. It says chemotherapy. So if it said biologic agents, I would treat it a little differently because biologic agents rev up the immune system. So if I'm giving someone a biologic agent, I'm looking for answers that show I know it revs up the immune system. Like if you're taking a biologic agent, you'd expect to have a fever. Okay. That's one example. In fact, you can have a very, very high fever. Sometimes they have to stop the medication if it gets too high. Okay. But I'm talking about chemotherapy. So I'm going to look for things that I know typically are associated with chemotherapy. Okay. So neutropenia is associated with chemotherapy. That's true. Neutropenia is low white count. Remember, lymphoma affects the immune system, but it doesn't affect the white blood cells. Okay. It affects the B cells, the T cells, and the natural killer cells. So when you have problems with those cells, you are immunocompromised and you can die from that immunocompromised state, but it doesn't so much affect the white cells. So the neutropenia is affected by the chemotherapy. Okay, that's very common. Pulmonary toxicity is a symptom of chemotherapy. So I'm not sure. I know that chemotherapy is very, very toxic. That's why people lose hair. That's why people have neuropathy. There are people who I've heard say, if I knew the side effects of the chemotherapy, I never would have gotten it because they might lose their taste. And they might have chronic neuropathy that causes so much pain. They're like, I'd rather be dead than have to have this neuropathy. So I know chemotherapy can be very, very toxic, but I haven't necessarily heard of pulmonary toxicity. So I'm going to keep that as a maybe. Peripheral neuropathy, that's very common associated with chemotherapy. Hypercalcemia. So I think, well, if it's is this a bone problem? Is this really considered a bone problem? And it's not really considered a bone problem. If they had like myeloma, multiple myeloma, I think there'd be more likely they'd have hypercalcemia because they'd be doing bone destruction stuff and they'd be releasing the calcium. But I don't think that's associated with the Hodgkin's lymphoma or the non-Hodgkin's lymphoma. Cardiotoxicity. Now, I will tell you, this is just from my personal experience. I haven't read it anywhere, but I know chemotherapy is very commonly causes cardiotoxicity. I've taken care of patients. I've met people I know who are getting chemotherapy, and they had to have like every month they had to get an echocardiogram because they'd have to stop the chemotherapy if it caused toxicity to the heart. So I know cardiotoxicity is a common side effect or toxic effect of chemotherapy. Increased risk of secondary cancers. So anytime someone's neutropenic, they have an impaired immune system, their white count is low, plus they have lymphoma. So all these things going along together, they're at risk for other cancers to pop up. Do you know what the number one protection, the number one body system that protects us from cancers is our immune system? So our immune system identifies self versus non-self. So anything that's non-self, that even includes cells that replicate, that now know, that have devolved to look like it's not us anymore, right? So the genetic code changes because it's replicating and it doesn't look like the original cell. Our immune system goes and attacks it. So we are protected from all kinds of nasty cells that our own cells can turn into by our immune system. So anytime someone has chemotherapy, they're at risk for increased risk of secondary cancer. So I know neutropenia, peripheral neuropathy, cardiotoxicity, and increased risk of secondary cancer. So the question is, should I pick pulmonary toxicity? So I like to teach you how to guess, right? And for me, I'm not sure what I would guess, because I've told you before, I would rather you underselect than overselect, because we're very prone to overselection. And because we're so prone to overselection, if you're not sure about an answer, I'd rather you not select it for a SATA question. So I'm not sure if I would pick it, because I know chemotherapies are so toxic that it certainly could be toxic to the lungs. So I don't know if I would have picked it. So I'm just here to tell you that the chemotherapies that are associated with treating non-Hodgkins and Hodgkins are toxic to the heart, the lungs, the nerves, and the white cells, all those things. And they're very, very aggressive chemotherapies. There are some chemotherapies that are much less aggressive, like the chemotherapy that a man might take for prostate cancer, much less aggressive, way fewer side effects and toxic effects. But it's actually the round of chemotherapies that are used for Hodgkins and non-Hodgkins are so aggressive that they have a ton of side effects. So for this one, whether you guessed yes or no on pulmonary toxicity, if you didn't select it, it's not that big a deal. You get partial credit for the SATA questions on NCLEX, but I'm just here to tell you that these chemotherapies are highly toxic to like so many body systems. A 67-year-old patient with non-Hodgkin's lymphoma, which is more common in older adults, is experiencing night sweats, fever, and weight loss. How should the nurse interpret these findings? Symptoms of dehydration, side effects of chemotherapy, symptoms indicated disease progression or normal aging changes. Well, I told you at the beginning, so do you remember what I said? That so normally they have painless enlarged lymph nodes. That's sort of what they originally have. They may have some fatigue as well initially, because all types of lymphomas, leukemias, cancers, they all can cause fatigue. That's pretty common. But as the disease progresses, if they don't get it treated, or if they are being treated but it's not working, they eventually will have night sweats, fever, and weight loss. And that's just because their immune system is so screwed up with all of these weird cells and changes to the T cells, natural killer cells. They're just doing weird stuff. And so they have these like symptoms that the immune system is stimulated, right? Why does our temperature go up? It's because we have a fever because our immune system goes up. And then when our fever breaks, we have sweats. And then weight loss is always associated with progressing cancer, always. So that's why they have these symptoms associated with that. A nurse is teaching a patient undergoing chemotherapy for Hodgkin's lymphoma about preventing infection. Which instructions should be included? So anytime someone is going through chemotherapy and their white count drops, neutropenia is lower white count, we should put them on neutropenic precautions. So the question is, do you know what neutropenic precautions are? So let's see if you know what they are. Avoiding raw fruits and vegetables is part of neutropenic precautions. That's actually true. And that's just because they could carry bugs on them and different pesticides and different things that if your immune system is compromised, you don't want to have access to, you don't want your body to be exposed to that. So that is neutropenic precautions. Performing hand hygiene frequently is part of neutropenic precautions. I hope everybody knows that is true. Getting a live vaccine to boost immunity is part of neutropenic precautions. That's not true. Do not get live vaccines when you're under neutropenic precautions. You can get non-live vaccines. So like you could get the flu shot, but you can't get the flu nasal spray because the flu nasal spray is live, the flu shot is not. Avoid crowded places is part of neutropenic precautions. That's true. Okay. You can either avoid crowded places, or if you go to crowded places, you should wear a mask. They don't always have to wear a mask. Neutropenic precautions does not require them to always wear a mask, but they do have to wear a mask when they're in crowded crowds. Part of neutropenic precautions is reporting a fever of 100.4 or higher. That's true because if they get a secondary infection, they're not going to be able to fight it off. So they need to report those. Part of neutropenic precautions is instructing them not to drink water standing longer than 4 hours. So that's a little bit of a trick question. Standing water, if you don't know what the word standing water means uncovered water. So a cup of water. It doesn't mean a bottle of water with the lid tight on it, or a closed bottle of pop or something like that, right? It's a standing water. That English phrase means something that is uncovered. And they actually have to discard standing water after 15 minutes. So they can have a bottle of water covered or in the fridge or whatever, and they can keep drinking from it however long they want to. But if they leave it uncovered, maybe accidentally, they put it down, they forget to put the lid on it, and half hour later they come back and go, oh, I forgot to cover it. They got to discard that water. 15 minutes is as long as you can leave water standing. Now, other parts of neutropenic precautions, the staff no longer has to wear a gown or a mask. Remember, we used to call neutropenic precautions reverse isolation. We don't do that anymore because the staff doesn't have to wear a gown and mask. Vital signs every 4 hours is part of neutropenic precautions. Paper plates, so disposable plates and cups, is part of neutropenic precautions. That's all I can think of right off the top of my head. I'm sure there's a couple more. If you don't know what they are, you can just Google it and see what they are. A nurse is prioritizing care for a patient with advanced non-Hodgkins, which is the bad type, who reports difficulty breathing and facial swelling. What does the nurse suspect may be the cause? Tumor lysis syndrome, superior vena cava syndrome, spinal cord compression, or pulmonary embolism. So I'm going to cross off pulmonary embolism because we have facial swelling, and that's not a symptom of pulmonary embolism. So tumor lysis syndrome is when the tumors are being broken down so quickly that it actually starts, the remnants of that actually starts to like collect in the kidneys, and it can cause kidney failure. That's tumor lysis syndrome. So I would expect to see some kidney symptoms here, and I don't see any of that. So I'm going to say no to tumor lysis syndrome. Superior vena cava syndrome is when the lymph node gets so enlarged, it actually presses on the superior vena cava. So if it's pressing on the superior vena cava, the lymph node, what symptoms would you have? Well, the superior vena cava returns blood to the heart. So if we have less blood returning to the heart, we may have facial swelling because you could get backed up lung, right? So where's it going to back up to? It's going to back up to the neck and the face. So you could have facial swelling, and you could have some difficulty breathing if you don't have as much oxygen carrying capacity because of decreased blood return to the heart. So superior vena cava syndrome seems to make sense to me. Spinal cord compression, that also can occur when the lymph node presses on the spinal cord, if the lymph node gets so large that it presses on the spinal cord. But I would expect neurologic symptoms if it was pressing on the spinal cord, depending on where it's pressing. If it's pressing in the thoracic area, that's the mid-back area, I would expect to see some probably constipation, decreased bowel sounds, and some difficulty coughing because the thoracic area affects the muscles of the abdomen. If it was in the lumbar area, if the tumor was pressing in the lumbar area, the low back, I would expect probably some urinary retention or some lower leg problem moving, or maybe numbness in the lower extremities. So it just depends, but that's not what I have here, right? So I know it's not spinal cord compression. So the only one that makes any sense here is superior vena cava syndrome. A patient undergoing chemotherapy for Hodgkins lymphoma, which is the good kind, reports a fever of 101. What is the nurse's priority action? So I'm concerned about that because they're immunocompromised. Notify the healthcare provider. I would think I'd want to do that. Encourage increased fluid intake. That's not going to help if they have a underlying infections. Consider acetaminophen as ordered. What is the nurse's priority action? So this means I can only do one thing. It doesn't say what are you going to do first. So I have a patient with a fever of 101. If I notify the healthcare provider, I don't administer acetaminophen. But if I administer acetaminophen, then I don't notify the healthcare provider. And I really have to notify the healthcare provider, because with priority, it means you can only do one thing. It's very theoretical because there's never a time in real life that we can only do one thing. So that's why it's a little trouble sometimes when we get these kind of priority actions or best questions, because we're like, I want to do them all. Well, you can't do them all. So which one do you have to do? Which one shows that you really understand the significance of this situation? Well, I have to notify the healthcare provider because they could have a secondary infection that could cause a lot of problems. Obtain a sputum specimen. Maybe we're going to want to figure out where the source of the infection is, right? I do want to do that, but I'm not sure a sputum culture is what I want. Maybe I want a urine specimen. Maybe I want something else, right? I don't know. So I need to call the healthcare provider to figure out what we need to do, because I don't have enough information to know what to do. So the healthcare provider is going to have to decide. A nurse is caring for a patient with non-Hodgkins lymphoma who develops facial swelling, shortness of breath, and distended neck veins, which sounds like superior vena cava syndrome. What should the nurse do first? Administer PRN diuretics, assess for signs of infection, provide supplemental oxygen, elevate the head of the bed. Well, before we decide, let's see which of these are appropriate. So is it appropriate to give a PRN diuretic in superior vena cava syndrome? Facial swelling, shortness of breath, and distended neck veins. So I don't have crackles in my lungs. That's not the issue. It's not a crackles in the lungs. It's a tumor, the lymph node tumor pushing on the superior vena cava. So would diuretics help that? I don't see how diuretics would help that. It might temporarily get rid of the facial swelling, but it seems like what we'd really have to do is remove the tumor from pressing on the superior vena cava. Assess for signs of infection. That doesn't seem to address the problems here. Provide supplemental oxygen. Maybe, but the only time I would provide supplemental oxygen is if it tells me their O2 sat is low, and it doesn't tell me that. So I'm not crazy about C. Elevate the head of the bed. Okay, elevating the head of the bed does do a couple things. It addresses the shortness of breath, right? So I like positioning. Positioning is always a good thing to do when someone's short of breath. It addresses the swelling in the distended neck veins by allowing some of that blood to drain just through gravity. So actually elevating the head of the bed sort of addresses all of those things. Signs of infection doesn't. Supplemental oxygen only addresses if they were hypoxic, and I don't know that they're hypoxic. And diuretics might address the facial swelling and the distended neck veins, but it doesn't address the shortness of breath because it's not a fluid volume overload problem. So elevating the head of the bed actually addresses all of those. And so I like that answer. It's really the only one that addresses all the problems. And sometimes when you're looking at what you should do, sometimes you're looking to see which answer addresses the problem. So always make sure the answer you're picking is addressing the problem that's being presented in the question. A patient with non-Hodgkin's lymphoma is receiving rituximab, a monoclonal antibody, which is a biologic agent, by the way. Monoclonal antibody is a biologic agent that revs up the immune system. Which assessment finding should prompt the nurse to stop the infusion immediately? Which assessment finding should prompt the nurse to stop the infusion immediately? So I'm going to stop it if something unexpected occurs. Now, I've talked about drugs that end in MAB in the past, and I've said they're immunosuppressants, and this is very confusing to me. I'll be honest with you, because drugs that end in MAB are biologic agents, and sometimes they suppress the immune system and sometimes they rev it up. I don't know always which one does which, but I do know in this case, we're not going to want to suppress the immune system in non-Hodgkin's lymphoma. Like I can't imagine we want to do that. So I'm thinking this one revs up the immune system. And if it revs up the immune system, you'd expect signs and symptoms associated with that. So let's see what we have here. Mild headache. I mean, that's pretty expected with revving up the immune system. How do you feel when your immune system, like you get exposed to a bacteria or a virus and you're not really sick yet, but your body's immune system is revved up, right? You just don't feel well, like general malaise, slight fever, headache, like those are all kind of common, right? So headache seems like expected with the monoclonal biologic agent. Fever and chills, that's expected. Your immune system's all revved up. That's what you feel like with a revved up immune system. Shortness of breath and hypotension. Well, I don't expect that when my immune system is revved up. Fatigue and nausea. I mean, when my immune system's revved up and I'm sick, so to speak, right? My I have a fever, I have malaise, I'm fatigued, I have muscle aches and pains, I have a headache, sometimes I may feel a little nauseated. Like that's all kind of expected with that revving up of the immune system. But I don't expect them to be short of breath with hypotension. In fact, shortness of breath with hypotension makes me think they're having some kind of an anaphylactic reaction, to be honest with you. So that's a problem. So I'm picking the unexpected finding here, the unexpected finding. So you always have to intervene immediately with the unexpected finding. So when you have the problem or the diagnosis and the question and all your symptoms are in the answers, one patient, all the symptoms and their answers, and say, what are you most concerned about? Which one's going to require immediate intervention? Which one are you going to call the doctor about? You always address the unexpected finding. A patient with non-Hodgkin's lymphoma, which is the bad one, is experiencing tumor lysis syndrome, which lab value requires immediate intervention. Potassium of 6.2, calcium of 9, hemoglobin of 9.8, or sodium of 132. So the abnormal findings are actually potassium, hemoglobin, and sodium. So the question is, which one is worse? Now, in clinic reviews, if you were to take our full review, what we would do is we would teach you different lab values and say they're A, B, C, or D, and the C and the D lab values are always the worst. And in fact, potassium of 6.2 is a D lab, hemoglobin of 9.8 is a B lab, and a sodium of 132 is a B lab. B labs, you just have to assess something. D labs, you have to do something. So if you had taken the NCLEX review, I would say this is a D lab. You have to do something about the potassium. But if you haven't taken that, let me explain to you why that is. So first of all, the heart's very, very sensitive to potassium. So when the potassium goes high, because the high end of normal is 5.3, so if it gets high, we're concerned about cardiac dysrhythmias, right? Well, why is it high? What is it about tumor lysis syndrome that causes it to be high? So if you don't know this, the vast majority of the potassium in our body is stored inside the cell. The serum potassium level is 3.5 to 5.3. But you know what the intracellular potassium level is? It's about 160, right? And so most of the potassium is stored in the cell. So when you have a tumor lysis, it's breaking this tumor down. Do you know what it's releasing? One of the things it's releasing is potassium. So tumor lysis syndrome, as it starts to tear down that tumor, not only can it cause problems with the kidneys because that sediment from the tumor breaking down can get stuck in the glomerulus and can cause problems, but it can also lead to hyperkalemia. So those are a couple things to think about with tumor lysis syndrome. A patient with non-Hodgkin's lymphoma is at risk for tumor lysis syndrome. Which intervention is most important? So the last question was, which lab are you most concerned about? So now we say they're at risk. What are we going to do to try to prevent it from happening? Encourage a high potassium diet. Well, no, that's not going to prevent anything. Increase IV fluids to maintain hydration. So I told you that a lot of the problem with tumor lysis syndrome is the sediment ends up going to the glomerulus and it clogs it all up. So if we maintain fluid volume, if we give them fluids and maintain hydration, it would dilute that out a little bit and you wouldn't have so much of a problem with that. So that sounds like a good idea to me. Administer an opioid for pain relief. That doesn't do anything to prevent tumor lysis syndrome. Monitor for signs of peripheral neuropathy. Peripheral neuropathy is a symptom of or a side effect of chemotherapy, but it's not a symptom of tumor lysis syndrome. So if we want to prevent tumor lysis syndrome, is that what it says? Risk for this? What intervention is most important? So it doesn't say prevent, but it's sort of a prevention is maintain their hydration because it dilutes out all the sediment that's coming from these tumors that are breaking down. A patient with lymphoma, doesn't tell us what kind of lymphoma, either Hodgkin's or non-Hodgkin's, receiving chemotherapy, asks why they need frequent blood tests. What is the best response? We need to check your liver function. It ensures you're responding to treatment. It checks for allergic reactions to the medication. Chemotherapy can affect your blood cell counts. Okay, what is the best response? So I can only say one thing. So as it relates to chemotherapy, I don't think we need to check liver function. That's not a high priority to me. I do want to know that they're responding to treatment. So that may be reason. So I'm going to keep B on my list. To check for allergic reactions to the medication. Well, we don't do lab tests. blood test to check for allergic reactions. So C is out. Chemotherapy can affect your blood cell counts. Okay, that's true. That can do that. So is it more likely that I'm doing lab tests or blood tests to check if they're responding to treatment or to see because chemotherapy can affect your blood count? So when you've got it down to 2 like this and you're not sure, reread the question. A patient with lymphoma receiving chemotherapy asks why they need frequent blood tests. So the word chemotherapy is in the question. And D has the word chemotherapy in the question. And although we're doing chemotherapy to make sure that we want them to respond to it, right? But the reason we do frequent blood counts with chemotherapy, if I answer the question that's actually being asked, we do frequent blood tests with chemotherapy to make sure they're not becoming neutropenic or anemic. Like that's why we actually do it. We don't have to do frequent blood counts to see if they're responding to treatment as it relates to chemotherapy. We could probably do once a month. We're probably doing weekly blood counts when they're on chemotherapy. So if I reread the question and I say, okay, I'm going to focus on the chemotherapy aspect of it, not just the treatment aspect, but the chemotherapy specific, then we would be doing that because chemotherapy can cause neutropenia and anemia and some electrolyte imbalances and so forth. Patient with non-Hodgkin's lymphoma. By the way, I have my dog right down here, so I'm petting my dog. So if I look weird, that's why. A patient with non-Hodgkin's lymphoma asks why they're receiving allopurinol along with chemotherapy. What is the nurse's best response? So allopurinol is a drug that's used to treat gout. Okay, it's a drug that's used to treat gout. It prevents the uric acid from settling in the joints. Gout is a type of arthritis, and it results from uric acid, which is can be produced from different types of food that you can eat, settling in the joints. It helps prevent nausea caused by chemotherapy. Well, allopurinol is not a nausea med. It protects your kidneys by reducing uric acid levels. That seems likely, knowing what I know about allopurinol. Prevents low blood cell counts. That's not what we give allopurinol. It strengthens your immune system. Allopurinol is used to treat gout, which is a uric acid issue. So I didn't know we gave allopurinol with non-Hodgkin's lymphoma. Like I didn't know that. But I do know what allopurinol is, and I know it relates to uric acid, and the only answer that says anything about uric acid is B. So I'm going to go ahead and pick it. So you don't overthink these questions. Say, well, I don't know. I didn't know we gave allopurinol, but I know what it's for. So I'm going to pick the answer that shows at least I know what allopurinol in general is for. It's related to uric acid. So I'm going to pick the answer that says uric acid in it. Okay. I'm not sure if somebody, when you asked me to cover this, I hope I covered it the way you wanted me to. It was not a comprehensive review of Hodgkin's and non-Hodgkin's lymphoma. You know, this channel specifically is geared towards passing NCLEX, what you need to know to answer NCLEX questions, and also any standardized tests that you might take in your class. So I hope that was helpful to you. Hope you understand a little more about lymphoma and the B cells, the T cells, the natural killer cells, that it's not a leukemia, it's not a low white cell count, but it is an immune problem. It can be treated with chemotherapy. It can be treated with biologic agents. And the symptoms are primarily painless lymph nodes. The Hodgkin's is more controlled where it's located. The non-Hodgkin's is more spread out and much more likely to kind of spread, which is why it's more deadly. Hodgkin's can be found in both children and older adults, whereas non-Hodgkin's is mostly found in older adults. So I hope that summary was sort of helpful to you. I don't know much more than what I just taught you. And I don't really need to know more unless if I decided to work with non-Hodgkin's and Hodgkin's patients, I would learn a whole lot more. But as it relates to standardized tests, honestly, you don't need to know much more than that. So I hope it was helpful to you. Have a great rest of your day. Bye.